We're fortunate that today there are many treatment options available for men with castration-resistant prostate cancer, and it's likely we're going to have even more in the coming years. Right now, we have a menu of options available for our patients of therapies that are used in a variety of different contexts and have a variety of different mechanisms of action. So for over a decade, we've had chemotherapy, we've had docetaxel. We recently added cabazitaxel to that list, so we have 2 taxane-based chemotherapies. We also have radium-223, also known as Xofigo. This is an intravenously administered radioisotope that's indicated for men who have symptomatic bony disease. It's really for patients who have bone-only disease and pain from that. These can be patients who've already had chemotherapy or who are unfit for chemotherapy. Then we have the 2 AR-directed therapies, abiraterone and enzalutamide, and those are both available for patients who are chemotherapy naive or who have already been treated with chemotherapy. And finally, we have Sipuleucel-T, a cellular immunotherapy, which is really a treatment that's designed for patients with metastatic castration-resistant prostate cancer who have a slower moving form of the disease and a sort of more slowly progressing form of the disease. Enzalutamide has been shown to improve survival and delay disease progression in 2 contexts. In one, it was in patients who had previously received docetaxel. That was a study that was called the AFFIRM study, and it was reported a few years ago. It led to the approval of enzalutamide. This was followed up with a study called PREVAIL, which was enzalutamide versus placebo in patients with chemotherapy-naive castration-resistant prostate cancer. Now, in that study, enzalutamide demonstrated a clearly significant benefit in terms of progression-free survival compared to placebo. The median progression-free survival in that study was about 18 months, and the median survival was about 33 months. Both of those were statistically significantly better than the placebo arm. So in that context, enzalutamide has really become a very logical choice backed by level 1 evidence for use in the chemotherapy-naive patient population. In general, enzalutamide is quite safe for most people who take it. There is an interesting story about enzalutamide and the potential safety issues that pertain to its penetration into the central nervous system. At high doses that we don't use anymore, there were seizures seen with this drug. At the current standard dose of 160 milligrams per day, we don't see seizures, but what we have seen are some definite fatigue type of a definite fatigue type of a syndrome. There have even been falls have been reported with this drug, and there's some speculation that there might be some neurocognitive deficits that occur, such as memory, even depressive symptoms in a certain group of patients, and that's something that's been recently reported. Abiraterone has been shown to be effective in both delaying disease progression and improving survival in both chemotherapy-treated and chemotherapy-naive patients with metastatic castration-resistant prostate cancer. This was based on 2 phase 3 studies. We call them the 301 study, which was the post-chemotherapy group, and the 302 study, which was the chemotherapy-naive group. In that group of patients, the median progression-free survival, I'm talking about the chemotherapy-naive group, is about 17 months, and the median survival for that group of patients when treated with abiraterone was over 35 months. And so this is now backed by level 1 evidence and is considered one of the standard therapies for castration-resistant prostate cancer. Abiraterone's mechanism of action is to impair androgen production in tumor and in the adrenal glands. But what was noted very early on in its development is that it can cause something of a reflexive mineralocorticoid excess. And what can happen there is patients can develop retained sodium, which manifests itself as edema typically, and loss of potassium. So hypokalemia is a risk when a patient takes abiraterone by itself. Now, when a patient takes low-dose prednisone, those mineralocorticoid levels and the mineralocorticoid side effects are drastically reduced. Yet, patients do continue to need to be monitored, and so the monitoring for a patient treated with abiraterone would have to do with potassium levels. Certainly, patients then who are taking low-dose prednisone would need to have blood glucose monitored from time to time, and liver function tests need to be monitored as well.